My name is Jennifer Malloy. I've met a lot of you, and if I haven't met you already, I'll definitely make an effort to come and say hello. But my name is Jennifer Malloy, and I'm the CEO of the Royal University Hospital Foundation. I would like to acknowledge that we are gathering on Treaty 6 territory and the homeland of the Dakota, Lakota, and Métis. Recognizing this history is important to our future and our efforts to close the gap in health outcomes between Indigenous and non-Indigenous peoples by knowing what the land and the traditional people of the land offer us. Tonight's meeting is intended to update you on the progress of Dr. Mita Manna's project, and you will hear from her shortly. But as we start a new year, I also wanted to take this time to personally thank you as well. As donors to WLTP, you are making a tremendous contribution to women in healthcare. You are providing an opportunity right here in Saskatchewan for our physicians, healthcare providers, and allied healthcare professionals to address issues specific to women, which is ultimately improving lives, changing the landscape of healthcare, and providing families with critical information that will result in better healthcare outcomes for generations to come. As an ally to advancing women-led initiatives at RUH through your passion, commitment, and contribution to women leading philanthropy, a real change is being made, and we thank you. WLP is now in its 6th year, and because of donors like you, we have raised $700,000. I would be remiss to not remind you of the impact of your support and the transformational change that this program has created in just 6 short years. Your investment in this amazing group of women has shortened the wait times for genetic testing for uterine cancer patients, supported a physiotherapy project for mastectomy patients, changed the outcomes of surgical care for women with gynecologic cancers, provided access to HPV testing to those with reluctances and limited access to testing, and provided patients living with MS new hope through early intervention. Thank you. This is a dynamic group of women, and I hope this short recap reminds you of all how we can empower each other and achieve transformational change in healthcare for women and their families. Which brings me to a very exciting update since we last met in September. I am very happy to share with you that a grateful patient of Dr. Manna's, and I worked with this donor who is extremely grateful to Dr. Manna, who she feels saved her life, stepped forward after the voting meeting to provide an additional $50,000 of additional funding for Dr. Manna's project. And Dr. Manna will talk more about it, but her project is advancing precision medicine for breast and ovarian cancer patients through genetic testing, a pilot program in Saskatchewan and one that we'll all benefit from. This additional funding will afford Dr. Manna the opportunity to further enhance her project, which she will share with you during her update. Another true testament to the change we are making as donors to this amazing program. Thank you. Speaking of amazing women, WLP is so fortunate to have 2 such women who will be our hosts this evening. Our program chair, Dr. Mary Kinloch, and I practice this word all day, Division Head Anatomic Pathology for the Saskatchewan Health Authority. Mary stepped forward to support WLTP when it was just a vision, and so graciously continues to support WLP with her leadership and guidance. And Maeghan Dubois, Manager of Communications at Campotex, RUH Foundation board member and fellow WLP donor. Maeghan has generously shared her time and talents over the last year as a co-host when our honorary co-chair, Rachel Milkey, has been unable to join us in person. So welcome, Mary and Maeghan.
Okay, thank you so much, everybody, and welcome. Thanks for the introduction, Jen. So my name is Mary Kinloch, and I am a gynecologic pathologist. So anatomic just means anything that comes off of the body. So if you get anything taken from your family doctor or an endoscopist or a surgeon, that all comes to the lab and you look at it under the microscope. And I am delighted to be here tonight and just very inspirational. The January meeting is often a time of reflection and is apt for this point in the year. And whether you've been here since the very first Women Leading Philanthropy meeting or you're just joining us, this one is going to rock your socks. Like, we have some big things to announce that you've already heard Jen talk about, but really we're starting to see this snowball action of the things that we have come together to work for are really starting to make large impacts throughout RUH and the patients. So we're really excited to have two conversations. So we're going to have one with Dr. Manna, as well as and how our project has evolved, and we're going to also talk with Dr. Marilyn Baetz. And Dr. Baetz is the interim dean for the College of Medicine and also one of the vice presidents for faculty engagement at the University of Saskatchewan and an inaugural Women Leading Philanthropy donor, to talk a little bit about how Women Leading Philanthropy has, as a program, inspired and affected female physicians at the university as well as RUH.
Thanks, Mary. So when we empower women, we all benefit. Women, our families, and our entire community. Women Leading Philanthropy continues to inspire me because, and my notes are in my binder. I asked Mary.
I'm sorry. I ensured her that we had the same script, but that's because I don't have a script.
She doesn't use a script. Okay, I'm not nearly as talented. No worries. So, Women Leading Philanthropy continues to inspire me because for me, this is such a unique program that puts the donor directly in touch with the physician and healthcare, and not to mention unites women on all fronts: donors, healthcare providers, and patients. Women supporting women is such a beautiful and impactful approach to creating meaningful change. As an RUH Foundation board member, it makes me so proud and incredibly grateful that we have some committed and engaged donor group that is leading this program. And that brings me to my next point. Along with all of you who contribute to funding the 100,000 WLP grant each year, I want to sincerely thank our generous sponsors and acknowledge our gratitude for their support. So I'm going to read them out. Thank you to MNP, Bayer, Aspen Films, SO Asher Consultants, AstraZeneca, Encore Global, D&M Images, Handy Special Events, Kenny Lamoth Strategy Design, Hilberg and Burke, and Vera Lingo. Let's give them a round of applause.
And a lot of those sponsors are here tonight. And just as a reminder, the sponsorship that they provide keeps your donation 100% tax deductible. So thank you very much for the ongoing support. So last September, Women Leading Philanthropy donors were presented with 3 outstanding projects that were all worthy of the $100,000 grant. And as the inspiring event came to a close, we all elected Dr. Manna to be the project winner. So I'm very excited to hear tonight an update from Dr. Manna about the progress that she has made in her project, Advancing Precision Medicine for Breast and Ovarian Cancer Patients through Genetic Testing, a program pilot in Saskatchewan. So let's take a few minutes now to watch Dr. Manna's application video to refresh us on the project.
Hi there, I'm Dr. Mita Manna, a medical oncologist at the Saskatchewan Cancer Centre. As a provincial disease site lead for breast malignancies here in Saskatchewan, I've seen the faces and stories of countless women battling breast cancer. It's a fight that touches 1 in 4 women in North America. At the same time, ovarian cancer casts a shadow as one of the most formidable gynecological foes. Now let's unravel a bit about what causes cancer. While some causes are linked to things around us, like chemicals and smoking, genetics can also play a role. So imagine this. Think of your body as a puzzle book. Each piece in the puzzle is a gene, a tiny instruction that makes you who you are. Sometimes these genes can have little changes in them, like a typo in a book. These changes, called mutations, can increase the chances of certain cancers like breast or ovarian cancer upwards of 60 to 80%. Genetic testing is like reading the pages of your puzzle book to see if any of these changes are present. So if a woman is identified to have a genetic mutation, such as the BRCA mutation, then it allows the patient and their clinicians to make informed treatment decisions. For example, this could mean having a double mastectomy rather than breast-conserving surgery, or the addition of targeted therapy, or even having a loved one initiate early screening with MRIs or having preventative surgeries performed.
Hi there, my name is Krista, and I'm a breast cancer survivor. Being diagnosed with cancer is already difficult, and then having to wait years for genetic testing, it's like running a marathon of stress. But do you know what would ease that stress? Spotting those mutations early, that's the key. My journey with breast cancer took me through several surgeries, one of them being a lumpectomy, and then 3 years later, a bilateral mastectomy, before I found out that I was BRCA mutation positive. Then underwent a third surgery for a double mastectomy. Imagine if I'd have known about that mutation sooner. I might have been spared those surgeries altogether. And think about my children. Mainstreaming could bring them answers sooner, revealing their risks for cancer. Patient mainstreaming isn't just a solution, it's a lifeline. It's understanding the urgency, offering a path to swifter answers and better care. Quick testing means rapid solutions, prompt treatments, and more moments to cherish. It's reclaiming control over their situation. We're not just talking about tests, we're talking about moments to savor, to fight, and to live.
Patient stories like these embody the essence of what we are unveiling: mainstreaming. It means that your cancer doctor, like myself, can order genetic testing directly for you. We're therefore bypassing the need for separate pre-test genetic counseling and thereby streaming the path to knowledge. Our aim is swift access to crucial information that can guide decisions and improve outcomes. Waiting times, which were once measured in years, will soon be reduced to a matter of months. Time is precious, and mainstreaming recognizes that. The beauty of mainstreaming lies in its simplicity. If a mutation is found, we then connect you with experts like Tara, who will guide you through the genetic landscape.
Hi there, I'm Tara, genetic counselor at the Royal University Hospital. Mutations in genes like BRCA drastically increase the chance of breast and ovarian cancer. Right now, getting tested for these mutations is measured in years for women in Saskatchewan. And that delay greatly affects their treatment options and maybe even changes their lives. And that's why we're here, to make a change. Waiting to spot these mutations can have huge consequences. Information is powerful, and knowing if these mutations are present may impact surgical and treatment decisions, as well as impact screening for family members. With mainstreaming, we are right here to help. Think of us as your genetic guides. We'll help you understand your risks and explore personalized choices.
This is a journey of patient empowerment. It's about harnessing information, about putting patients at the center. Mainstreaming isn't just a step forward, but it's a leap towards a brighter horizon for cancer care in Saskatchewan.
So let's join me in welcoming our 2023-2024 Women Leading Philanthropy Grant recipient, Dr. Mita Manna. Congratulations again, Dr. Manna, on being selected for this funding by our WLP donors.
You were successful in captivating your donor audience with your proposal of advancing precision medicine for breast and ovarian cancer patients through genetic testing, which also inspired a grateful patient to come forward and provide additional funding for your research. What does this additional funding mean for your project, and what have you accomplished so far?
Thank you, and thanks everyone for coming out tonight. And once again, I'd like to thank each and every one of you for, coming out, representing and providing this wonderful fund to get this project up and running. So it has been, very overwhelming since we were awarded the grant in the fall, and since then, my team and I have been working hard to try and get the project up and running. And so with this additional funding, we have been able to do that. And I'm very pleased, to see where we are today since October. We've been able to gather as a team. I have many different people on my team, not only medical oncologists, but breast surgeons, gynae-oncologists, geneticists, lab medicine, as well as research facilitators, all involved in terms of trying to make sure that we get the pathway well outlined, make sure we're all aligned in terms of how things will roll out, because we are communicating between different elements in the healthcare system. So we have the Breast Health Center, we have the lab at the Roy Romanov Provincial Lab, we have genetics at RUH and the Cancer Agency as well. So it's a matter of how are we all going to work together and how are we going to implement this. So with this funding, it really lit a fire. Everyone's really excited to get the project underway. Everyone is motivated and invested. So the first thing we did is, of course, we had the proposal in place, and then with that we were able to implement sort of our pathway. We've created an online OneDrive system for us to be able to access all of our documents, pathway systems, requisitions, any resources that we need, so that way we can communicate without sending too many emails nonstop and being overloaded that way. And we've been able to work together as a team to get to where we are right now. Along with this process, we've also had to implement a lot of the research framework in order to get all our ethics approval underway, because in order to conduct this project, there's also a research element as well. And in order to do that, we have to apply for ethics and get the green light in order to proceed with this project. So that has been a lot of work, and of course, just before coming here, that we had the holiday season, so there's always a little bit of a lull. So our goal was to try and get everything submitted well before the holidays to make sure we can get things underway for 2024.
So if you can remind the donors, if you had a patient before this project, they would get their breast cancer diagnosis, they would come and see you, you would identify that they would need to go see medical genetics, send a referral, and now the waiting game starts.
Correct. So that was the biggest thing, was the waiting game, was the fact that I wasn't able to order the blood test. I would have to first get them seen by medical genetics. And because of the short staffing, the wait times, the limited availability, sometimes the wait times could take up to 4 to 5 years, depending on the waiting time and the severity of things. So that was the wait time where they'd have to first see medical genetics, then they were sent to get blood work. The turnaround time would take maybe about 2 months or so, then they would get their results. So you can often see that patients were waiting upwards of 5 years or so to get that testing done.
So
Yeah.
now, how are patients going to be identified and referred to the medical genetics team? What's going to change?
So the biggest thing that's going to change is we're bypassing that first meeting with medical genetics. So what happens is specific physicians in the region, so those who encounter patients with breast and ovarian cancer, so the breast surgeons, like some of you might recognize Dr. Harrington on that video, myself, the gynae-oncologists, we will be able to identify patients who are high risk, so there's particular criteria that needs to be met. Based on that criteria, we'll identify patients. We will then actually counsel patients on what it means to get the genetic testing done. We will then provide them with the lab requisition. They go to their local lab, they get their blood work done, and that turnaround time should take about 6 to 8 weeks to get those results. Those patients who have a positive result will then meet with medical genetics in we're anticipating about 3-month time from the time of result to meeting with medical genetics. But we will then get that result and be able to act on it. So that timeline is significantly reduced. We then open up resources and more valuable time for the medical geneticists to be able to spend on patients who are identified to be
But
positive.
it's not just about the medical genetics at that point, because now if you're getting the result that quickly, what other options do the patients have?
Yes, that's very important, because as mentioned, that result identifies to not only the surgeons but to the medical oncologists how their treatment pathway will be modified. So for example, if they do harbor that mutation, they're at very high risk of breast or ovarian cancer, so those patients are then eligible to undergo a double mastectomy. So instead of undergoing, let's say, a breast conserving surgery first, and then years down the line you're found to have a BRCA mutation, then you go for a double mastectomy, then you might have your ovaries removed. But having the results up front, you don't have to go for the lumpectomy first, you go straight for your double mastectomy. So that spares multiple surgeries, multiple OR times, multiple times going under anesthesia. Finally, on top of that, not only were we fortunate to obtain funding from a private donor, but we've also obtained additional funding through AstraZeneca as well, because we also have targeted drugs that we're also able to utilize for patients who harbor a BRCA mutation. So once we identify those patients with a mutation, we're also able to provide them with therapy that can impact these patients in terms of their long-term survival. So this is extremely important. We have data and evidence to support the use of these medications that are transforming the world of our oncology care. So we're able to counsel these patients in terms of their surgical management, therapy options, and on top of that, if a patient is identified to have that mutation, we know that it is hereditary. So that means other people in their family could be affected, not just women, but also men. So then they are eligible to undergo testing and undergo preventative screening or treatment as necessary. So the long-term benefits are incredible because they add up.
Not for breast cancer, what cancers do they get for? This is all of a sudden becoming a one-on-one, like a test for Mita. This is her Royal College exam. What cancers do men get that are BRCA mutated, Dr. Manna?
Pancreatic cancer is also a risk factor as well. So ovarian cancer for women, but we also have other cancers like pancreatic cancer, for example, and that there's no screening test for that type of cancer. We're not going to go in there and surgically remove the pancreas prophylactically, but there are other risk factors, other cancers that can develop as well. So.
Thanks so much. So it sounds like there's many organizations working together on this project, and you had mentioned the ethics piece. Can you just walk us through what that process looks like?
Oh, ethics is a wonderful journey. So, if you go through the healthcare system, and when you encounter a healthcare professional, you are essentially consenting to, undergo, treatment and tests, and, everything is strictly confidential between your healthcare team, and that's sort of your standard of care. But if there's any studies that are going to be conducted, so let's say, I'm treating XYZ patient, but I want to see, did X patient do better than Y based on, this drug, or what are the outcomes? I can't just conduct that research. I can do the analysis and keep it to myself, but if I want to share it with Mary or with anyone else, I need to get that patient's consent. I need to say, are you okay if I take your data and utilize it for X and Y, Z purposes? So I need to obtain that consent, and there's the processes that are involved is essentially applying for ethics. So there's different sort of jurisdictions that I need to go through because there's a lot involved in this project. As I said, there's a lot of, I'm working with RUH, the Cancer Agency, SHA. So first I had to apply for ethics through University of Saskatchewan to say this is the project I'm doing mainstream, but on top of that I also want to get consent from these patients to be able to collect their data to know, are we making an impact? What's the improvement? What's the benefit? What's the health cost analysis? So I'm very grateful to say that, got approval the other day through REB Ethics, so that's the first step. So they've given us the green light to proceed with that. We've gotten approval from SHA to say that, we can, utilize their data and use any, if we need to access certain records or what have you. So I've got approval from SHA. And as of Friday, I should get final confirmation from the Cancer Agency, because I will also be utilizing the electronic records for patients. So what we've done is we've tried to unify it all. So if a patient goes for mainstream testing, that requisition and their consent form will all be scanned into the electronic records at the cancer agency. So it's just one area for us to be able to log in and view the records. And then we'll be able to collect the data on patients who have provided consent. And then essentially we're going to be able to then, come back and say, out of this number of patients who've obtained mainstream testing, these are the ones who provided consent. This has been sort of their tests were positive or negative. They received this type of surgery, this type of, treatment. These were the outcomes. And then, we also want to do a health cost analysis, right? If this patient didn't have testing, if they didn't find out that they were BRCA positive in time, what cost would that have been to the healthcare system, for example? Because ultimately, your funds have been, crucial at initiating this project, but ultimately we have to sustain it, for the long term.
Can you imagine, this must be music to the foundation's ears, that if every donor intervention that you had, you got a full health cost analysis about what your impact was afterwards. So I'm hoping that you're going to be with us for a few years to tell us about the long-lasting impact that this has made. So how have you been getting the word out to the clinicians? What kind of promotional communications?
It's like herding cats. We were able to, it's about trying to get together in meetings. So I've been we had our first meeting with the gynae oncologist to essentially get the word out there in terms of what we are conducting, what the purpose is. And, we'll be having another meeting down the road to essentially provide them with a mock session in terms of how to counsel patients on obtaining the genetic testing. So, we've been setting up virtual meetings with the physicians during working hours. We have multidisciplinary meetings where we often, at our tumor board meetings, where we discuss patient cases. And so we'll be presenting on that platform in terms of, this is what's coming out, this is what needs to be, what everyone needs to understand and know what the requisitions we're using, where they can access it, who to contact, the consent forms that are needed. And then on top of that, I'm pleased to also say that this year is the second year we have our provincial breast meeting, which last year we had over 100 healthcare professionals, including veterinary medicine, who showed up. But so this year we're hosting it again early February, and I hope to also have a similar number of attendants because this includes surgeons, oncologists, pathologists, radiologists, everyone from all spectrums who treat breast cancer. So that's going to be our major platform to announce mainstream testing to all healthcare providers in Saskatchewan, because this is going to be, broadcast to those who are not locally in Saskatoon. There will be a virtual option as well.
Are we hearing about that before everybody else is then?
Yes. So we will be updating all the healthcare professionals about what mainstream is, what we're going to walk them through the pathway, all the paperwork that needs to be done. Everyone loves the paperwork. And we are hoping that it'll be formally launched February 2nd. So that is very exciting.
So here we are in January. You said that when the voting meeting happened in September, it was like, okay, now it's go time. And we've already heard how far you've come. Looking ahead, what are you hoping to accomplish by the end of the year?
It's incredible how far we came. I'll even give a backstory to this, because at the first provincial meeting, which was last January, I remember when Tara, our medical geneticist, and she sends her regrets she wasn't able to attend today, she made a plea, we need to somehow come together and figure out how we're going to get mainstream to Saskatchewan. And, yes, the foundation was crucial, and here we are today. So I'm hoping that a year from now, mainstream, of course, will be up and running. We'll have not only been able to get patients who are newly diagnosed with breast or ovarian cancer onboarded, but we're also hoping to go back and, clear out the patients who are currently on the wait list. There's about 500 to 1,000 patients on that wait list. And so we'll be notifying those patients that, mainstream is now up and running. You are now eligible for this testing. Your healthcare professional, it has to be certain healthcare professionals will be able to order the test for you. So we hope to work our way through that wait list build up as well. I'm also talking to others about how we can elevate this to the next level, and I think that would be sort of the next phase in terms of, right now we have, strict criteria in terms of who can get testing, and that's in place for the province. And our goal is, if we are successful with this in a year, we'd like to expand that criteria to meet guidelines that are, international. And we also want to look at, if you harbor this mutation, can we figure out, did you inherit it from your mom's side or your dad's side? So essentially doing parent of origin testing, which would really make the testing more efficient when you're looking at testing other family members. So how can we, make it easier for the lab and more efficient? So can we take it to the next level, right? So I think with all the funding from the foundation, our gracious donor, as well as AstraZeneca, all these funds will help launch mainstream, and then we're just going to hopefully take it further after a year.
Like, you very clearly shot for the stars here, and I do think that, like, once you get that first win, once you get that idea that you have somebody standing behind you and supporting you, then it's just, the sky is the limit here. And so, because those last two were not really part of the original, but you're like, if I can do this, then I'm going to be able to make Saskatchewan the best place for patients who need precision testing for breast and ovarian cancer. So we're looking at, so how many women do you think in this first year it's going to touch?
I think it will touch at least, we have approximately, I think it's going to touch about 500 women probably for the first year that are newly diagnosed.
Yeah.
This is throughout the whole province. So we're talking, not only patients who are seen in Saskatoon, but also Regina, and there's some patients who are seen in Moose Jaw,
Right.
Prince Albert. So I think it's going to probably affect about 500, active patients. And then we're also, as I said, it'll take time for us to clear that wait list, because not everyone's going to necessarily get tested right away. And if they don't agree to get mainstreaming, or they don't get it done right away, they're not taken off that wait list. Like, they will get tested eventually, but it's an opportunity for them to get tested sooner.
So I think that that's maybe one of the things that we can explain about how the donor impact happened, is because to try and get this, I'm peripherally part of this in the lab, but it's a separate lab that's doing the testing. So I was on some of these meetings with Dr. Manna to try and appeal to the health authority to get this started. But one of the large barriers was this wait list, because everything in health authority works with a budget, and you have this budget for this amount of time, and there is no deviation from that. There's no extra money to be able to clear that wait list. So it could never really get off the ground, because how were we going to go above the run rate for the budget for the testing? And then when the WLP grant came in, they just couldn't say no. Like, there was no other option but to facilitate this through and make that work. So I think it was a really concrete example of the impact that this group has made, and now seeing what all is going to transpire over the next few years for these patients.
I think it's really exciting, and I'm so grateful that everyone on my team is invested. No one is getting paid overtime to do all this extra work, ethics meetings. Everyone is so excited to get this project up and running, and I think that's the key, is that everyone also believes in this and is motivated. So without that, we wouldn't have been able to get to where we are today with all 3 ethics approvals underway. I think when I outlined in my proposal, when I was looking back at it, phase 1 we were supposed to actually commence in January, and that was getting all this done, but we were already ahead of schedule. So I think everyone's very motivated and excited to get this.
Oh, we're delighted to hear it. Thank you so much for joining us tonight and sharing
Thanks
us.
for having me.
Can't wait to hear you come back in June to give us another update. Yeah. So now we're going to introduce Dr. Marilyn Baetz, and as I mentioned before, Dr. Marilyn Baetz is the College of Medicine's VP for Faculty Engagement, and is sitting with us as the Interim College of Medicine Dean of the Medical School. So welcome,
very much. Thank you for being here with us tonight. So we appreciate you carving out your time in your extremely busy schedule, which I heard has shifted now in your new role. For those in the room who may not know you as well as others, would you mind sharing a little bit about your professional background and the work you will be doing now with your appointment as the Interim Dean at the College of Medicine?
Sure, thank you so much, and it's such a pleasure to be here. I've been here for many years as part of this program, and it's just really exciting to be in this warm room with a full crowd at in this cold season, cold day, I should say. I'm going to just start a little bit way back, just so you know. I'll start way back in the old days when I grew up. I grew up in rural Saskatchewan, around Gardner Dam, Beaver Lake, and I grew up and I knew I was going to go to university, but I didn't have a clue what I was going to be, and there was nobody around at that time in our area that would have ever been that I knew that was a physician. So I went into university, and I took a science degree, and I worked as a dietitian for a number of years, and I was in the hospital, and I saw these people, and they were students and they were residents, and I thought to myself, my goodness, if they can do it, I can do it. And at that time, I went into medicine, and it was certainly nothing that I would ever regret. And I found I had a little, my niche was really in psychiatry, and I was very interested in people who are fascinating, and in every specialty there's always going to be something that is interesting, but people, they're all different, right? As in other areas, you know, once you see osteoarthritis, you see osteoarthritis. But when you're in psychiatry, people always add a little spice to it. So that's how I got into psychiatry, and shortly thereafter, you know, during my residency, I had my first child, and then right after that, I had my second child. And that was in the days when you really didn't have too much time to spare. So I had like 6 weeks off with my first and 5 months off with my second. And I had taken on an academic psychiatrist role, which they had at that time, which meant I was part of the university as well as part of the health district at that time. And had my job was to see lots of patients. I had to see inpatients, I saw outpatients, I did call, I did night call, I did day call, and I had to teach, and I had to do research. And you can imagine, you know, doing research off the side of your desk, which a lot of doctors still have to do when they try to do it, is actually very challenging without any support. And yet part of your goal is to advance academically. You want to go from being an assistant professor to an associate professor to a full professor. And that's based on a lot of your academic work, which includes teaching, but also research that you have to do. And so that was a really difficult time, a real scramble, and I think of all those years, you know, the challenges that it had, and often by yourself doing that. So eventually, over the course of a number of years, what happened is we were having difficulties finding a permanent head in psychiatry. And being the last person in the room one day, I think I ended up becoming the department head for psychiatry, and that was a decade-long experience. But through that, I had the amazing opportunity to start to advocate for people who had been in my situation, to advocate for supports for research within the department. I had great opportunities to, actually I worked with Arla for a number of years. We had great fun, really, in many respects, looking at different ways to support and help mental health, but also, you know, the RUH Foundation had grants for people to apply for research, which was wonderful. They weren't specific to women at that time, but they were a start. And that was a really great opportunity. I also mentioned that I worked with the most amazing dyad partner. So my partner was Tracy Mugley, who some of you may know, who's actually now an executive director at St. Paul's Hospital. And Tracy was the director of the health, well, at the time it would be the mental health, which would be the operational side of, and I was the head of psychiatry. And we were partners together, and we were, as females, the first female dynamic duo, I always say, that we were able to make a lot of inroads. And we were able to move ahead, and so that was really positive. And from there, I then moved into the role of Vice Dean for faculty engagement in the College of Medicine. And that is a role that, so just for those that don't really understand it's hard to understand, academics is a little hard to understand, but as a physician, I have a clinical component, and I need to have a clinical component, but we also do teaching, and and very often we do research. And so although I'm part of the health authority, that's my clinical part, most of us, like about 2,000 physicians in the province, are also part of the university, and so they would be faculty. So I actually help to support all of the faculty in the province for their academic component as well. And so you can see that there's a lot of opportunity for individuals to be engaged. Most of them are engaged with teaching our undergraduate students. We have about 400 undergraduate medical students and about 400 residents who are in different kinds of training. So that's the part that I oversee as the Vice Dean of Faculty Engagement. And I also had the opportunity, which I'll tell you a bit later, about looking into how do we improve the ability for our physicians to advance from assistant to associate to full professor, so we can be competitive across the country as well. So now, I think I left the room again at the wrong time, and now I am the interim dean for the College of Medicine. And so we do have a full search underway for a dean, and but the role of an interim dean is really to hold the fort. But not really, like I don't want to just hold the fort, I want to keep going. I have a lot of things I want to get done in these 6 months, right? You know, and I didn't want to take on 10 years, but I thought I'd do something for 6 months to a year. And so I've hit the ground, as who was saying, Mita was saying, I hit the ground running, yeah. And I was just saying, I don't have there was no on-ramp for me, it's just been going. And so that's great, because we have lots of plans. We have plans to continue to expand. We want to get our learners out into the areas of the province that need physicians, so that we know that if they train there, they're more likely to stay there. And we're really, like, I have a real goal to try to increase the research productivity and to increase the equity that we have. The gender equity we have a long way to go with EDI, but we still have a long way to go with gender equity. And I think that's another piece that I'm going to say. So lots of things to be involved with, and happy to do them. Every day there's something new that comes across my desk. Mostly it's, did you know the last dean promised me this? And I'm like, so I have to find out some of those things, but it is actually great fun. So that's a long-winded answer.
Well, I think that, and the practical side of the vice, I think I called you a vice president at one point too, so elevated
well,
that.
I had to
for
correct
you.
myself because I see the president's wife here, so I just want to be careful.
As the vice dean of faculty engagement, so I'm medical faculty and Dr. Manna's medical faculty, and it wasn't until Dr. Baetz came around and did almost like a road show, like a real promotional tour about this is how you get promoted, that I went from assistant to associate professor. And part of that was because I was able to get one of those research grants from the RUH Foundation back in the day. And so you gotta, it's those things, and people don't realize it earlier on in your career, but it's those things that you need to be able to advance, not just on the university side, but you can't be the department head or the provincial head of a department if you aren't involved in that research side, that scholarly side. Yeah. And so for those career ambitions to include, now part of the reason why we do research is because it keeps you not only with the patient impact, but it keeps you being a really sharp doctor. Like, you're always going to make sure that you are on the cutting edge because you're creating it. So that's really important. But I was wondering about what the significance of having those grants now that are dedicated just for women, and what impact you're able to see with that from your lens.
It's actually, and that was the point I was going to make, it's been wonderful to have grants available, but to have grants available just for women has had, I think, a really significant effect. And I was thinking about, what would I say would be the top three, and I have maybe 3.5, but I have 3. So the first thing I think is that, when you have a grant that's available for women, it empowers women researchers, because it actually is something that they can focus on, it's achievable, it actually levels the playing field, I would say, that's been very biased to males in the past, and I might go into that in a bit later, but you know, it allows it to make it reasonable, realistic, and the way that it's set up is not so hierarchical, and it's not so you know, getting some of the grants and things from other areas is just, you have to know the system and you have to know somebody in the system, and often women, you know, aren't necessarily either have the time or the know in some ways as they start out, so this has been really good. I think the other thing it does is it actually changes the mindset. So not only is it women that are looking and wanting to get grant women physicians, but we're thinking about how can I help my female patients, my women patients, and I think that adds another really unique aspect to it, because it really helps to focus on what are some of the, and believe it or not, many of the things that women have can be understudied compared to men. And so this actually allows to shine a light, you know, on that as well. And then I think what we saw tonight is just another shining example of how this type of a format and this type of project gives education and understanding for all of us. Like, I learned a lot, and I'm sure that all of you have learned a lot. And except for Mary, who of course tells. But you know, she had, you know, all of this has all just been very helpful and really helped us to see, to give an insight to a little light into the world that seems so mysterious. And you know, I love hearing about the projects, and regardless of whether they were winners or not, you know that for sure that they are just such interesting areas and fantastic insights. And I guess another piece of that then has been, not only has it been educational and you know, brought a lot of understanding, it's actually spurred on philanthropy. And have you seen that? You know, where it's not just with Dr. Mita, but there's been others who said, I was so inspired by that project, I'm going to give extra to it. And you know, that's really what the goal is, that it's touched us, we understand where it's at, and we can move forward.
Thank you so much. So we're not going to leave the EDI space just yet. So you had mentioned that there's a lot of room to grow in this area. So what barriers have you seen for women for academic advancement in medicine, and do you feel that WLP has addressed these barriers in Saskatoon?
So it's a really interesting one, because certainly when I first started out, this would never have even crossed anybody's path to think that there might be any issue, you know, that there would be any inequality. But people have started to look, and they realized, you know, if you look at across the board, women were often given less time to do research. They were often, even if they were particularly given less time, they often had more career interruptions, and then you would be penalized for maybe taking time off for having children, taking parental leave, having, you know, if children are sick, you're the one usually having to spend the time away. And so when you lose that time, you lose the opportunities. You have perhaps less publications, you may have less less opportunities to apply for funding. And when we looked at the amount of funding that people would get, there would often be quite a bit of difference between how much males got and how much females got when they applied. And you know, women's publications would tend to get into journals that maybe weren't read as frequently. We call it lower impact, and men's seem to be higher. If people were writing a letter of support for women, it would often be, oh, she's a nice person, but if she has a family, and then the man has a lot of potential and great, you know, and things like this. And you wouldn't believe it, but then you started to see these studies that were done, and I can certainly see it. I remember when I first joined the research committee a number of years ago, I just asked, you know, okay, you know, how much have we given for startup funds for the males and how much for females? And it was just phenomenal, the difference, you know, that was there. But by bringing light to that, everybody was motivated to make a change. And of course, society has really helped us along in that way. So that's been great. So those are just a few examples of things that were there. Oh, one more I have to tell you. You know, many of our drug trials over the years, the drug trials, you know, there's drugs that both women and men take that are the same, right? But the drug trials would be mostly done in men because they would exclude all women of childbearing age.
Well, sure, the hormones.
Right?
Yeah,
And so you are taking medications that were tested on men, doses tested on men, and you know, and just things like that, you know, that happened over time.
Well, what have we seen? I'm just trying to remember what some of the criteria that you needed for to move to associate professor, and there would have been that component of publications. So what do you think of something like Women Leading Philanthropy, how it's supporting physicians in their academic pursuits?
Well, you know, that is exactly the exciting part about it. But you know, to advance from an academic from assistant to associate to a full professor, you do need to have you need to have been involved with publications. You do need to have had grant success, and you do need to have had various other measures of research. And when individuals get that kind of funding from a WLP, it's part of your funding, but it also allows you to apply for other things, more funding in a different area, and that breeds. So a small bit of seed money is so important for the next step, and we've seen that. I've actually seen it 2 or 3 times within our own, in these last few years, individuals that have gone forward successfully for promotion, and they've had a WPL grant. So so I mean, maybe I shouldn't tell tales out of school, but that's really been a positive thing that's been helpful, already.
Well, that's amazing. Yeah, I think that probably the people who are from finance background in the room, leverage would be the buzzword here. You could really leverage the money.
Yeah, you can leverage the money.
To get more funding and to get more in kind. And it gives you a bit of a cachet, and I definitely think that Women Leading Philanthropy is starting to get that within RUH, that it's like, oh, I was one of those Women Leading Philanthropy recipients. Like, people know what that is now, which is very cool.
All right, and so I get the last question here. As an inaugural donor to WLP and a member of the board of the RUH Foundation, what has inspired you the most about what WLP has accomplished?
Well, I mean, there's obviously been so many things, but you know, the one thing I was thinking about, and it sort of refers back to what I was talking about, was when I was the department head, the provincial department head, I was working with a partner who wasn't a physician, who was amazing as well. And Tracy and I, as I was saying, we worked together. It was really well. We had different skill sets, but we were able to accomplish more than if we had obviously been doing anything on our own. And I see this program very, very similar. We have the women physicians or healthcare workers who are doing the research, but they have the partnership with the women in business and industry, and different skill sets, different backgrounds, but the synergy that happens working together is really exciting. And I just really feel that teamwork and working together in that type of capacity is really important. And you know, it is obviously the inspiration that comes from encouraging our women and our researchers. And it's an excellent excuse to wear a lot of Hilbergenberg.
Oh, that's great. Well, that was a really great question. So as like a newer board member, Megan, like maybe the same question, like what has inspired you most about being part of the Women Leading Philanthropy group?
Great, thanks so much. I do want to acknowledge that we have some long-time WLP donors, but also some new donors, and then maybe some potential donors in the audience. So I just want to welcome you all. This meeting, for those that you who haven't joined the program yet, it's our second meeting as part of that cycle. And so I did speak about it a little bit at the beginning, but as an RUH board member, but also as a mother, a daughter, a friend, it makes me incredibly proud of the work women are doing to support other women. So I look out into the audience, I see some faces, some old friends, and it's really inspiring that it's women for women. And I do often try to explain to other people from outside the WLP program what this is all about. You know, they maybe have heard about it or seen it on social media. And so I tried to begin by telling them. And then I say, you know what, you should just come for yourself. Because it's once they attend in person and they hear from these incredible women like Dr. Manna and Dr. Baetz, and most importantly, they feel the presence and the warmth and the support in the room. And they feel the passion and the commitment for women's health, and that they understand that the uniqueness and also the impact that WLP has in the community and the lives of women who benefit from this life-changing research. So for myself, empowering women is a theme that is very central to me. whether that's raising the next generation of women or supporting other women in the industry. My industry is mining, but also, or women in healthcare. I feel very privileged to be able to be part of this program like WLP and get to know the women, like all of you in this audience tonight. So that's my shtick.
Great. And thank you so much for coming and chatting with us tonight. And thank you for everything that you've done for the College of Medicine. It has been very heartwarming. I am clinical faculty, but I am part of the medical faculty, and I feel very welcome at the university, and a lot of that is due to your engagement. So thank you
so much, and absolutely. That's really my goal, is just to
Yeah.
have people feel engaged and want to be part of it.
Absolutely. Thank you so much. Thank you. Okay.
All right. All right. So we can go, maybe I can say this part. So before we go this evening, we know there's much excitement around what we heard this evening. And if anyone has any questions for Dr. Manna or Dr. Baetz, that we welcome you to come forward with any questions you may have. So
Great questions from the audience before I think that everybody has. Yeah. I think that we just have like a lot of inquisitive donors, and like as you get more information, it's going to spur more questions. So we want to encourage to make sure if you have any questions for Dr. Manna that they're answered here.
Oh, awesome. Trisha, do you want me to run? I can run the microphones.
I think
Oh,
I
you
can
think
speak loud
so?
enough.
Okay.
I just want to know, for the people that you have to get consent from, do you get usually about 100% consent, or people don't want to consent?
That's actually a really good question. So are you talking about this project in general, or? So we haven't initiated it quite yet, so we don't know what the consent rate will be. Our goal is obviously 100% consent, and we gave the consent form, easy to read, easy for people to understand, and also we want to minimize also the workload from the physicians, because we all are asking them to take on more, right, to spend that extra couple minutes to talk about genetic testing to get that consent performed. And so our goal is to get 100% uptake, but my concern is not so much from the patient side, but it's actually from the physician side. And so I think we're gonna try and come up with some solutions to help that. And I think this is another area where we can say, let's say our uptake is low, right? And if we identify it as the physicians who are struggling, how can we make a plea for additional resources to help out? When it comes to drug trials and sponsored trials, for example, at the Cancer Agency, we do have those sources readily available. So we have trials nurses who are able to help sit down with the patient, go through the consent form, spend that extra time to obtain that consent from patients. So it takes away that extra strain from the physician, right? Because often when I'm seeing a patient in, let's say for the very first visit, I only have an hour dedicated with that patient. Of that hour, 15 minutes is maybe spent with the nurse to get the vitals, intake, all of that, and then I'm spending 45 minutes going over your diagnosis, your prognosis, maybe your treatment, side effects, what to expect, going through all of that, and that's 45 minutes, that's not a lot of time, right? And I want to try and dedicate as much time as possible, answer as much time as possible, and then on top of that, I'm probably going to have to say, well, you're eligible for genetic testing. Before I would say, I'm going to send the referral off, you'll hear from them, that was it. Whereas now I'm going to have to spend time saying, this is what genetic testing is, this is what it means if it's positive, and I'll have resources for physicians to hand to those patients. But then I'm also having to spend that extra time being, well, if you agree to mainstream testing, you're going to get mainstream testing regardless, but I want to get your consent to collect your data, right? So you won't be denying mainstream testing if you don't collect your data, right? But then I'm spending that extra minute. So I feel that the obstacle will be more from the physician's standpoint, not necessarily from the patients, because I think the majority of patients we talk about genetic testing with, majority want it done. In fact, those who are not eligible want it done, right? So I think we're going to try and find some solutions to help with that, but ideally it would be 100%.
There was another question. Sure.
For Dr. Manna, I have heard that there is mainstreaming in the UK and in Norway. Would we be the first province in Canada to have it?
That's a really good question. So I'm actually been fortunate to sit also on one of the national boards across that's dealing in Canada because there are other provinces that have launched mainstream. So unfortunately, we're not the first. So BC has launched on not too long ago. Ontario has launched, as well as Alberta. So we have yet to launch, and that's why it's critical that we do, because we don't want to be left behind. And because I'm on this national board, I've also been hearing from the other provinces. For example, you know, in Ontario, they've had mainstream up and running for a few years now, but there are still issues and obstacles. So it's even that testing, like that turnaround time to actually get that blood test done. Some surgeons are saying it should be done within, you know, a week, but they're finding it's taking much longer. The other thing is too, we're very fortunate in our province that, you know, we're small, we, you know, I know all the surgeons offhand, I know all the pathologists, you know, everyone's available, everyone's, you know, working well as a team, whereas in Ontario, it's we've got different individual hospitals, different communities, different centers, so it's very disjointed. So they're struggling with some obstacles there. So I've been kind of learning from Ontario, from BC, you know, when we launch, how we launch and do it right, and learning from their mistakes. So unfortunately, we're not the first, but as I said, I want to elevate it so that we can expand our criteria and get other types of testing underway. Yeah. Mm-hmm.
My question is regarding the College of Medicine and whether there's any energy within the college around a topic of concern, I think, to women. And I'm just going to give a teeny bit of background. So I had a conversation with Dr. Lexi Regish because we were in a relationship. I needed to have ovarian cysts removed, have a hysterectomy. Fortunately, none of it was cancerous, lucky me. But in the conversation, we came up with the media attention to surgical sexism. And the issue that was brought to light by both, I believe, the Star Phoenix and CBC, that physicians, male or female, get paid less to do surgeries on women than on men. So the example, black and white, is surgery on testicles gets more money than surgery on ovaries. And unfortunately, the other part of that complexity is the testicle surgery, just to use that example, is kind of easy compared to the ovarian one, but unfortunately, the surgeons, you know, get paid less because men's testicle surgery is more valuable than women's ovarian surgery. I'm being very blunt and black and white in this, but so was the article in the Star Phoenix and CBC. So what I'm wondering is if there's any energy within the college, because my understanding is that we as women, as taxpayers, as voters, can put pressure, and probably must put pressure, on government to change that pay scale, just to use that example of inequity to women, and often inequity to female physicians, because more female physicians are doing, or surgeons are doing this. So I'm sorry to take that long.
Yeah, no, and that's an extremely, that's another area that in terms of equity and diversity and inclusion is just, there's been a number of articles that have been published, even in the Canadian Medical Association Journal, that have looked at the exact same thing, that it's so often, even in specialties that aren't as obvious, like, you know, there's a lot more women that go into obstetrics and gynecology because it is a hard, like, they can make more money in a different surgical specialty because we often have women that have more complex, surgeries. There may be a whole variety of reasons why it takes longer, and often the referrals go to the women of the more complex ones because they might spend more time talking to them and spend more time, you know, explaining things to them. So there's a whole area that is looked at and researched. It's really quite fascinating. And I think that the biggest pressure that anybody can put is really on the funders. So whether that be the government or the medical associations in terms of funding, but the other thing that can help level the playing field is a different funding model that isn't based just on how many procedures you do, but it's based more on time. And so there's a number of ways that we look at that. So certainly within the college, for example, we're a very small piece of that. You know, we're not the funders for physicians, but one of the things that we try to look at is a different funding model, so that as a physician, I'm not losing money for the type of procedure I do, but I'm also not losing money if I do research and if I do teaching. And I think that's a really crucial, another area that we really need to advocate for, because a lot of times you have to do those kinds of things off the side of your desk. And who does that? But women. No. So anyway, thank you for that question.
And the Saskatchewan Medical Association has taken it on, and it sounds like the Division of General Surgery has taken it on as well too, because they get the funding from the government and then they can choose how to allocate it, so how it is more evenly distributed. But it's very hot topic right now for sure. Anyone else? Oh, Oksana?
This is for Dr. Manna, so congratulations on the progress so far. I'm just curious to understand where the testing is being done for these samples. I understand most of the money, if not almost all of it, is going to actually fund the testing. That was the biggest barrier to mainstreaming in the first place. So is this happening in Saskatchewan or being sent out?
That's a really good question. So in order to deal with the initial burden of testing, because there's some cases that we were trying to expedite faster. So patients who had more aggressive type of breast cancer, for example, triple negative breast cancer, they would get expedited. Ovarian cancer patients were also already on the expedited list as well. In order to kind of deal with that influx of testing, we were actually sending out the tests to Alberta to perform it. So there was an additional cost for that. And then, you know, if it continued on, you're worried about the additional cost, inflation, all that stuff is factored in. So with this funding, what has also helped advocate is to do more of the testing in-house. So the goal is to do it all in Saskatchewan. So it's going to be done at the Roy Romanov Provincial Lab, which is located in Regina. And so because of this testing and because of this initial influx of testing, right, we're rolling out mainstream, we're going to try and hash out that wait list. The initial workload is going to go up, and so that's actually promoted them to try and get additional human resources involved. So whether it's the machines or also people who are going to help with the testing. So I understand that this spring they'll be able to hire more individuals to help with that, so we can keep it all in-house and not send it out to Alberta, because in that way we can keep the costs, you know, lower, hire people, and then sustain it long term. So that is my understanding. In terms of the long-term goal, we might have to send it out of province maybe initially while we're, you know, trying to get things up and running, but the goal is to do it all in that lab. Yeah, thank you.
We'll do the last question.
You know how much I respect you and as a colleague, but to everyone in this room, I hope what you've captured is not, this is like where medicine and cancer care is. Mita and I can give chemotherapy to 98-year-olds, never gonna question. But this, if you heard that one woman who has one surgery instead of 3, or you prevent or do surgery at 1, this is where healthcare has to go. And so if you think that literally you could save so many lives by this one test, that we would never have to use all of that money for CT scans and chemotherapy. So I just think as a philanthropy group, it's prevention and knowing that it actually has to start somewhere. And then there will be so many people in 10 years, even 5, that we are actually, the group, this province, is that this kind of money actually does so much more than we think about. It's the prevention. And I just have to say that we can sit here and say the genetics, but I just need to say it is the heart of oncology, and it is probably the most disrespected, the least funding that we get. They were pulled for COVID, they have to fax their own stuff, they have leaves, and it's just a disgrace to me as an oncologist that we can't access that. And so this is actually allowing those beautiful people who are gonna save our family members' lives to spend the time with the counseling for the people who actually have the positive test result. And I wish Tara was here, because I think, like, I want everyone in this room to really go home and hear what you've done, but you're doing it as an oncologist, taking it back to where, like, oncology really has to go. It's not just giving chemotherapy, and I commend you so much.
Thank you for that. And this is project as well is because, as Vicky said, they are, in RUH, but they're also part of the pediatric department. So often funding and everything goes overlooked when we're dealing with adult, genetics and cancer. So ultimately our goal is to try, that would be my goal, is to try and get them moved to the umbrella of the cancer agency. And so, right now I'm also trying to figure out ways for how we can crosstalk our electronic records so that way they can get access to that, make things more efficient when they're giving the post-counseling genetics, post-counseling sessions to patients. They're able to access our electronic records for demographics, information. It makes their workload a lot more efficient. And then eventually we can try and make a plea to have them formally under the cancer agency umbrella. I mean, this is, as you said, this is leverage, right? Because we are advocating, for them. We're their voice. As I said, Tara came to me, a year ago saying we need to get this up and running because other provinces were doing it and we need to get on this, right? And, we were able to, here we are today, right? So unfortunately, she and her son are homesick with a gastro illness, so she wouldn't come and spread that. But she has been, her and Andre have been, crucial for this. So yeah, this is a lot bigger than just genetic testing. And also to make to your comment, I also want to say that fortunately, if we're treating breast or prostate cancer, there is no pay discrepancy there. So that's one good factor. But I will also mention, for prostate cancer, we do mainstream testing for that as well. So that's the other BRCA mutation positive cancer that men can get. They were able to get mainstream up and running right away, but they're not doing a research component. So we will never get data to say, what are their outcomes? How are we sustaining it? We're not going to be able to analyze any of their data, but yes, when it comes to equity, they were able to get theirs up and running.
Well, and another little inequitable piece to mention, and I will be quiet after this. So after I had the hysterectomy and found out I didn't have ovarian cancer, then, or in the process of the conversation, Dr. Regish suggested to me, you may want to go and have genetic testing, because it's connected to a whole bunch of other cancers that also show up in your family. So this was before I knew it was not cancerous, but even if it isn't cancerous, what are the genes that I might carry that would be relevant to our 4 daughters and family members knowing about, right? So then I learned about the 3 to 4 year wait list to be on the public list for genetic testing, and I understand that. And to her credit, she said, should you choose to do this privately, there is a company that you can hire to test your genes and find out if there's information that you need to share with family members. So because I decided that $500 was a dollar value that I was prepared to pay, I was able to have that genetic testing, thinking, well, it seems like a lot of money, but we frivolously spend $500 on who knows what. And so then through Invitae was the company, got back the results and could share it with family members. What you're doing is something that most people cannot afford. I decided I could afford it. We could afford it as a family, and did it. But most people are not going to and can't. And it would have jumped our daughters, had it shown something in their lives, up the list of the public testing, because their risk factors would have shown up, is how I understood it.
Absolutely.
So I just have so much respect for that work.
Thank you to all of you, because without that, your generous contributions, we would not be where we are today. And I think, as I said, it's really lit a fire, because we've a lot of attention was brought to this, with all the social media announcements and just advertisements and everything. So we've had a lot of input and a lot of support, and I don't think I would be standing here where I am today making these updates and announcements. So thank you.
Oh, we could sit by the fire for a couple more hours, I think. No, thank you so much for your questions. Those are really that we heard the impact, and we heard personal stories, and we heard we delved a little bit deeper. So thank you for sharing. One last thing on the agenda is I think maybe you've all seen the door prize that was presented here at the front of the room. So each WLP donor has been entered, and I'm calling up Lisa Gibson, the gift shop manager from the RUH, to help us choose that lucky winner.
Don't give her a microphone.
We've got Deborah Dubois Dean.
Congratulations. She's not here. Okay.
Next. Is that you? Oh, I didn't know that. Sorry. All right. Okay. This could go on for a while. Leslie Topolo? Third time's the charm. Here we go. Right, Arla? Amanda Doucette.
She's here!
Amanda's here.
Congratulations, Amanda. All right.
And if you want to come shopping in the gift shop, we're open right now for your shopping pleasure.
That's right. And there's a discount, is there?
20% off. And there's a 50% off box too. Little treasures. Thanks, guys.
Perfect. Thanks, Lisa. So as you leave tonight, we hope this evening has inspired a deep sense of pride in the Women Leading Philanthropy program and the personal contribution you've made to help transform healthcare for women and their families. We've already accomplished so much in 6 years. After such an inspirational evening, I hope you will all be excited to talk about WLP with the people in your life, your friends, colleagues, and family. And I do want to do a plug. There is now an Instagram page, so if you haven't yet followed it, make sure you check it out. The handle is, there it is. It will be on there. Okay, we'll just watch when we're run through. I think it's Women Leading Philanthropy, or _RUH. So check that out. And of course, if you do want to learn more or you would like to become a member and you're not, please see Trisha or Jen or anyone from the RUH Foundation or visit the website.
Well, thank you so much for indulging us in our comfy, cozy attire for tonight. And Mita, I just feel like you were the racehorse that just needed the Women Leading Philanthropy grant to open up the gate, and you're gone. And we're just waiting. I don't know where the end is, but I don't know how long this racetrack is. But I feel like that's what you really needed to get going. So we can't wait to see what you have in store for us in the years to come. Thank you all for coming tonight. I can't wait to see you in June. Have a safe trip home.